And our next speaker is actually our questioner, and it's Richard O'Driscoll. Richard is a qualified social worker with an MSc in Managing Partnerships in Health and Social Care, and he has recently been seconded from his substantive role as Head of Older People's Commissioning to lead the transformation of discharge planning in the Addenbrooke's hospital system. And his topic for us today is delayed discharges are all down to social care, or are they? Richard.
Thank you very much. Can everybody hear me okay? Okay, I'll just give people a minute or two as one or two people are coming and going. Before I get into the presentation proper, I just wanted to say a little bit about myself. When I came into the hall today to sign up, somebody said to me, do you work for health, social care, or do you work for commissioning? And I said all three, because I work in an integrated environment. And I've been working across health and social care boundaries for the last 10 years, if not more. And in the last 7 or 8 months, I've been working for 4 organisations in Cambridgeshire. That's the County Council, the Commissioning Group, the local Community Health Trust, and Addenbrooke's Hospital, to try and work across the system to tackle some of the issues that result in delayed transfers of care. A little bit about the Addenbrooke's system for those that aren't familiar with it. Addenbrooke's Hospital is enormous. It's got, and there may be bigger hospitals around that people represent here, but Addenbrooke's has about 1,000 beds. At any one time on the Addenbrooke site, there are 10,000 people. So it's the size of a small market town, and it feels like a very, very busy place. Addenbrooke's is a hospital that has a worldwide reputation, has some, medically, it's got a lot of strengths, and the hospital has a great deal of pride. But in the local health and social care environment, at times it's felt somewhat aloof and somewhat removed from decision making. So the decision to take an integrated approach was quite a big step for Addenbrooke's. Okay, we've just heard in the last presentation about how long we've been talking about integrating health and social care. I mean, after all, they are part and parcel of the same continuum. Oops. There we go. That was the one I was looking for. So back in 1955, within the early days of the NHS, within the first decade, we had the health minister at the time questioning why we have difficulties bringing health and social care together. Now, at that stage, there was no mention of all those things we just heard in the last presentation, education, housing in particular. It was just about, we've got these 2 major areas in people's lives, and they're not gluing together. And it's, I think, pretty sad that here we are in 2013, and we're still talking about legislating to make health and social care come together. And I think the fact that we legislate and provide guidance is good. But I think the drive for integration has to come from people. It's about people like yourselves who've taken the time to come into a session around integration, to be leaders in the field, and to do what our last speaker just talked about, which is around, you know, not just looking at the issue from your own organisation's point of view, but looking at what are the problems we face, what are the kind of challenges that we're going to come across. So this morning I'm going to talk to you for no more than about 15 minutes or so, and I do want to open up the floor to questions, and I hope we do get some, because I think, you know, it is dependent on all of us to try and take forward the integration banner. But today I'm going to focus on delayed transfers of care. That's what they're paying me to do in my current job. But I'm going to try and give it an integration flavour and a partnership flavour. Okay, public messages around delayed transfers of care. How do the press see them? First one, this was from The Guardian. bed blocking on the rise as care cuts leave elderly stuck in hospital. That term bed blocking, isn't it disgusting, really? I just, every time I hear it, my flesh just creeps. I can't stand it. And I think, if nothing else, if everybody who left this room today challenged people every time they use the term, I'd feel like I've done a reasonable job today. Whenever a child has complex needs and are in hospital, I have never ever heard of them being described as a bed blocker, but somehow that's acceptable for older people with very complex needs. Even the Guardian there referring to bed blockers. So here's one that you might expect to, the Daily Mail. Bed blocking by elderly patients rise by somebody called Beezy Marsh, and then it goes on to explain what that's about. And just bringing it sort of closer to my own neck of the woods, we have the Cambridge Evening News. That was a month before I started my job, saying, tackling the problem of bed blocking. Well, I suppose it was a bit more positive in that it was suggesting that there was work going on to look at issues around hospital discharge and around complex discharge in particular. But still, we find that kind of term being used. Okay, so why are we concerned about delayed transfers of care in Cambridgeshire, and why are we concerned about trying to do something across the whole system? We have here a demographic graph. I think this is primarily over 65s, but within that there is a subset that particularly is around over 85s. It's the area where there is the most growth. So in Cambridgeshire we see year-on-year growth in the older population of about 3.6%, which is a bit scary when you look at what that does as we move forward. And when you break it down even further into significant long-term conditions like dementia and other major long-term conditions, you start to see an even bigger problem. And you don't see people with one nice, simple condition that you deal with. You see people with multiple conditions that all interact and all have an impact on health and social care services. If I had some economic slides here, I could also show the resources going down as this population group is going up, particularly in local authorities. And that does pose a major challenge, I think, for the whole system. Okay, bringing some stuff closer to home again, delayed transfers in the Addenbrooke system. So we've tracked them over a period of time, and what we've seen is a steady increase, some very high numbers. But behind all the numbers, there are other stories. And one of the things that we do, particularly in the NHS, I find, the NHS loves to benchmark and look at data. And when we've benchmarked the Cambridgeshire figures, and particularly Addenbrooke's figures, we don't do very well. We look like we've got an awful lot of delayed transfers of care. I don't know if there's anyone here from Oxford, but if there is, I'm delighted, because Oxford save us from being at the bottom of the table. And Oxford is a very similar kind of environment to the Cambridgeshire environment, similar kind of population, similar kind of challenges and pressures. But I think one of the things I've found as I've started to look at delayed transfers of care is that we all count, but we all count completely differently. So I talk to some of my neighbouring authorities and I say, what are you doing about all those, oops, sorry, just dropped my water. What are you doing about all of those people who need community rehabilitation, that we're counting as delayed transfers of care, they've had their acute episode, in Addenbrooke's, we count them as delays if they don't move on to that service. My neighbouring authority said, oh, they're in that ward down there, but we don't count those as delays because they're in that ward down there. So that's left me with a few questions around some of the figures that we see, and does really sort of suggest that we really need to dig down and look at what's going on. Okay, so delayed transfers of care are one thing, but they're only the tail end of the system. It's just the place where people come out of hospital, And they are the most complex people. You know, there are lots of people who get discharged from hospital very, very easily, very quickly, need minimal services, but there is a very complex group who need maximum input. But this slide shows you what's coming in the front door. And what we've seen in the last 2 years in Addenbrooke's in relation to over 85-year-olds is an increase very close to 20%. And what's even slightly more alarming is that within that increase, we've seen much more complex cases coming forward, and an even bigger increase in the numbers that find their way through to our complex discharge planning teams. So behind the 3.6% that doesn't look like too scary a figure, we've got some massive numbers coming through with very, very high needs. And those people have to go somewhere. Yes, they receive an acute hospital service, but they require an awful lot more than that going out of hospital. They require a range of services, and they require coordination across many organisational boundaries. Okay, and just to add to our challenges, when people leave the hospital, they rely often on a range of different community services, not just social care as the papers tend to kind of suggest and simplify, but a whole range of different services. Sometimes it's community rehabilitation, sometimes it's equipment, sometimes it is social care provision. But what we've seen in the Cambridgeshire system is not only does demand fluctuate, although generally head upwards, but capacity also fluctuates. So even when we think we've got capacity, sometimes it's not there. You know, sometimes we can't use a care organisation for maybe because there's a safeguarding concern, or we can't use community hospital beds because there's a staffing issue or some other issue. And so we find that on the capacity side there's fluctuation, but we also find that we've got a group of patients whose needs fluctuate. So there is something about requiring much more flexible services and not just trying to pigeonhole people into what's there. So about 18 months ago, there was a bit of a realisation in the Cambridgeshire system that we needed to do something, and it wasn't something that could just be managed within one part of the system. So we had sort of three main planks of work. The first one was around increasing reablement capacity. And when we talk about reablement in Cambridgeshire, we are talking about an integrated health and social care reablement and intermediate care service. There isn't a join between them. They are one service with one point of entry, and that service will provide for people's end-of-life care needs, and it will provide social care reablement type services as well, and community rehab in people's own homes. We significantly increased that provision. There was an investment from the county council whose budget was diminishing, but somehow they managed to find £2 million to employ about 60 staff, both in the community health provider service and within the independent sector. So there was a very big shift in resource. It hasn't actually done the trick we'd like it to do entirely, because further down the line we also face challenges in terms of domiciliary care provision. So we now find people move down the pipeline but don't necessarily move from reablement when we need them to. We also increased our inpatient rehabilitation, community inpatient rehabilitation capacity, but we tried to do this in a slightly more flexible way than had previously been the case in the NHS. So in the past, we tended to use community hospitals, but we found that they were very fixed in their approaches. There were lots of debates about whether a particular condition would respond to the type of resource that was there. We found that the lengths of stay were a bit excessive, and we just found the range of needs that we had to deal with varied quite a lot. So we commissioned a service from an independent provider, but we also supported that service with input from our Community Health Trust. So we had physiotherapists in particular, physios, OTs and nurses going into that service, and the gatekeeping for the systems, both community rehab services and social care interim beds, all being managed by one part of the system, the Community Health Trust. And then finally, the one that I'm going to talk a little bit more about in a second, our pathways. It says continuing care pathways, which is slightly misleading. What we were talking about here was looking at all of the hospital discharge pathways for complex patients, and trying to make them more simple, more straightforward, and more effective. So, why do we have a problem trying to do that? Here we've got a picture showing the current process for hospital discharge in the Cambridgeshire system. And in Addenbrooke's, we've got a new chief executive who's quite a formidable character. He's 6'7", he's Australian, and he has a nice turn of phrase. And when he saw this diagram, he said, and I'll try and do my best Australian accent, and I probably won't do it very well, so apologies to any Australians in the room, but he said something like, well, we've got a lot of resistance in this system, haven't we? And I think he's right. I think we have an awful lot of resistance. Every one of those boxes and triangles shows some kind of handoff across the system. And it doesn't take much looking at that to see why we might have a challenge. This is still a complex system, but this is what the redesigned pathways look like. And to get here, we worked right across the system. We involved user representatives, carer representatives, medical staff, and a whole range of other staff across the organisations. And I suppose while I'm talking about health and medical staff, I think we talk a lot about integration between health and social care. There's quite a lot of integration to be done within the NHS itself, I would hasten to add. There is quite a lot of silo working across professional groups. We came up with this approach. It is more straightforward, but it has to be implemented. You can't do the trick of just saying what needs to happen. You then have to do it. And to do it, you have to take different groups of people with you across different organisations. Okay, I've listed here some of the barriers that we've faced in doing this work. Some of them are around management information. The bald figures don't tell you enough. So you need something that gives you a system-wide view of what's going on for older people. You also need to have coordination across organisational boundaries. So we've set up a separate governance system that means that in relation to delayed transfers of care, we have meetings happening at every level, from chief executive down to individual patient level, looking at what's happening, monitoring what's going forward, and planning ahead. And I think one of the most significant things about doing that is that people have moved their position in relation to delayed discharges. They don't see delayed discharges now as something that's preventing the system from operating. They see it more as a symptom of a wider system with bigger challenges that need to be dealt with. So we have much more strategic discussions happening at chief executive level about how we shift resources generally for unplanned care. And then we've talked about a coordinated approach by commissioning together. And it's not always easy. Each organisation has their own challenges, their own politics, and we heard some of that from our last speaker. But I guess the bottom line is, if you're committed to making it work, you have to work through those issues. So it does keep us all very busy, but I think if you can keep going back to the patient, actually it becomes very simple, the patient, the service user. If you start by thinking what's important to them, how do you make sense of it, it does help cut through some of those organisational tensions we deal with. I've mentioned here, I won't go through them all laboriously, but there is quite a lot of research on what gets in the way of partnership and what gets in the way of integration. Systems are one of those things. Organisational changes are one. And in the work that I've been doing, we have a programme of activity that says what we need to change, we monitor what we're doing. And along with all good programs and projects, you have a risk register. And we've got organisational change up there, but organisational change isn't just affecting one organisation. All of the 4 organisations that are paying part of my wages are all going through organisational change at the moment. And I think that reflects some of the challenges that are around, the economic ones, the demographic ones, and the political ones. And I think it's going to be a feature of life for some time. So I think we have to just accept it and work with it as best we can. I've listed a few others. The IT ones are ones I've been struggling with personally for at least 10 years. People keep saying, if you could just join up your IT systems, it would all work fantastically. We haven't managed to crack it yet, and I think there is something about just recognising where you can join up, you should. Where you can't, you need to work with what you've got. But I am going to go around the stalls today and around the technology bit just to see if there's things going on in other places that we've missed that would help us, because I think trying to get information in the right place is pretty key. Biggest barrier of all is trust. In order for systems to work together, people have to be prepared in their organisations to give some things up. Could be power, could be resources. Would you give up power or resources, money, to somebody you don't trust? So when we all open our joint bank accounts, when we do, we generally trust the person that we're opening it with. It makes sense. How do these organisations develop trust? And I think the way they do is you have to get people in the room together, you have to get them talking, and you have to develop structures that bring people together. We heard about the Health and Wellbeing Board, and that's one way you can do it. In our approach in Cambridgeshire, we've gone for a slightly different way in relation to our governance arrangements. But people have to know each other in order to trust each other, and you have to see the world not just from the Addenbrooke's Hospital point of view, so that when Addenbrooke's makes a change and decides... Sorry. When Addenbrooke's makes a change and decides more people need to go into the community, you have to consider what impact does that have on the local authority, what impact does it have on community health services. And so you have to create an environment where you can safely have those conversations. Okay, quick list of achievements. I think we've moved away from just seeing detox as an issue on their own. We're now looking at unplanned care, and we're looking on it as a system challenge. We have a greater understanding of demand and capacity. We don't have enough yet, but we're working on it, and we're actually working with people outside of the health and social care environment. We're working with engineers to help us understand capacity. We've got a better coordinated approach. We have had significant improvements in some of the internal hospital delays, in assessment delays, and in process delays of different types. I'd love to be able to stand here and say to you, when I started in my role, we had 70 delayed transfers of care. At this point, we're down to 20. We're not there, actually. This is a work in progress. We have much more to do. But what we do have is we have sign-up from a lot of colleagues to support us with it. And we're working to get other people doing the same. But it's a long journey. I think I can hear something. It's a train. Okay, so the thing to remember, I think, with integration, that it is a journey, it's not a destination, and it's something that we need to consistently work at. Okay, and any questions?
Thanks very much, Richard. Do we have some questions for him? Just raise your hands and we'll get microphones to you.
Is it on? Yeah.
Yeah.
Excellent. Thank you very much indeed. I just wondered, listening to you, one of the things that I've found, I'm a GP commissioner, is that the length of stay is affected by the, how shall I put it? Well, what often happens is that the medical staff will consider a patient is ready for discharge, and obviously the social care is then delaying that discharge, whether it be to home or nursing home or whatever. And then the interim period, while the patient is then waiting for that social care package, means that because you're dealing with a frail elderly person with complex needs and obviously lots of comorbidities, they then start to tip over again, and they then become re-medicalised, and so the medical team come back in again and then, you know, go back over the same thing, and they end up having more tests, chest x-ray, referrals to various different teams, and then they sort of have to start the whole process over again. I just wonder whether there's a scope for somehow handing over the clinical governance of that patient once they're ready for discharge to a community governance medical sort of model, because the problem is whilst they remain under the governance, the medical governance of the hospital and the responsibility, those doctors will still continue to treat them in a very highly intensive way. I don't know whether I'm putting myself over quite well, but that just seems to me, it just creates more and more delays, whereas if you could get them, you can't get them out quickly because there isn't any way you can get them to. So is there scope for somehow altering the umbrella of governance for those patients?
I think that's a really good question. I think there are a couple of points in there. The first one was about people who essentially are ready for discharge, but the service isn't available. And then what happens to those people because they continue to be under the medical supervision of the hospital. And we have that issue some of the time. And I think there's a couple of challenges. I think one is that we don't start the discharge process early enough. We actually should start the process as soon as somebody comes in through the front door. But what we shouldn't do is we shouldn't do what hospitals have traditionally done and treated somebody as if nobody knows them at all before they arrive at the hospital. We should be gathering the community intelligence, often from the GP and from others, about what kind of support arrangements are in place for that person. And we should start to be planning with community colleagues at a much earlier stage. And then when the person is ready for discharge, you know, I don't delude myself that we're always going to have the capacity in the right place at the right time, but I do think what we should be doing is switching the responsibility, as has been suggested, to the community from the hospital. And one of the parts of work we're doing in Cambridgeshire around that is we're trying to set up a community referral point to be used both by GPs and the hospital, so that at the point where somebody's ready for discharge, they get referred to the community referral point and they sort out the package of care that will support that individual. Because one of the things I've noticed is that people's diagnosis of the kind of service that might be needed does change, and whether it's a medical diagnosis or it's a social worker looking at community resources, it sort of changes around what's available, I find sometimes. So we had an issue a little while ago where some of our community rehabilitation beds were closed, and suddenly we had a drop in the numbers of people for community rehabilitation, but an increase in those requiring reablement. So there is a bit of a switch, and I think to some degree that's okay. I think there's a menu of services out there that can all be of benefit, but somebody needs to coordinate them. Somebody needs to have sight of the range of services, take responsibility for the package and the medical oversight, and actually manage that transition. And I think too often we are still in our compartments, and people do get stuck there. I've also heard on the positive side, sometimes those people who get stuck in hospital go on to be really well rehabilitated as well, and sometimes come out with slightly less needs than when they were said to be clinically fit earlier on. But on the whole, the majority don't. The majority deteriorate for the longer they've been in hospital.
Thanks, Richard. We've got time for certainly one more question. Gentleman at the front.
John Wicks, I'm a Chief Officer of a CCG in the West Mids. One of the things Addenbrooke's is renowned for in DTOP management is the idea of your new chief exec to put a financial incentive in place for ward staff for getting their patients out at or around their estimated discharge dates. And I just wondered how that's gone.
I think it's gone very well, but I think one of the things that happened in relation to that issue, and for in case anyone missed the John Humphreys interview, our new chief executive came in and he looked around the hospital, spoke to staff, and one of the things people were saying to him was, if we had people ready for discharge early in the morning, then they're more likely to go home that day. And that somehow got confused with delayed transfers of care and complex discharge, because I think what he was actually talking about was straightforward discharge. Anyone who's had their procedure basically should be ready on the day they're told they're going to go. They're expecting to go, so it's in their interest to leave early. And people constantly tell me, if you don't sort out the medication early on, if you don't sort out the transport, sometimes people who should be going home and there's nothing to prevent it actually don't, because they hit these practical problems. So what he suggested was that those wards that managed, I think he said everyone out by 10, and those that were discharged by 10, he said he would reward those wards. So it's not an individual cash incentive, but it is a financial benefit to wards to encourage them to adopt that model.
Thank you, Richard. Well, we'll probably have to stop there because coffee time is coming up. Thank you very much, Richard, and
Thank
thanks
you.
to both our speakers from this morning.
Thanks very much.